Guys, we will be recording, so if you have any questions, please please inform that it's going to be recorded.
Yeah, and you can put your questions in the chat as well. So I'll be monitoring the chat, Bearcase. So if they have any questions, then I can either reply to them or I can answer them at the end.
Yeah.
So yeah, either if you want to talk, then you're more than welcome to, but you can put your hand up or feel free to use the chat.
Yeah.
Great. Okay, it's 5 past. Shall we start?
Yes, let's start.
Hmm.
So, guys, what we're going to do today, we're going to go through the internal medicine training interviews and what you're going to encounter. And in this 1 hour, how much information we can give you so that you get best prepared for the day. We're not going to get into too much detail. We're not going to overwhelm you. And please let me know, do a thumbs up if you have an interview date so we will know roughly how many people will be getting into interview this year as well.
It's quite a few, isn't
Excellent.
there? So yeah, that's great, guys. Yeah,
Brilliant.
that's
Very
really
good.
good to see, isn't it?
Very
Yeah,
good.
really good to see.
Um, Excellent. Very good.
I'd say that's the majority, actually. That's quite a lot of people. Very good.
Excellent. So what we're going to do, we're going to do a little bit of introduction. We're going to do a little bit of a breakdown of the interview structure. I'm going to show you a few stations. We're going to do an example clinical scenario. We're going to give you a lot of tips and tricks, and you will be able to ask questions. And let's introduce ourselves, who we are. My name is Berkay. I'm a rehabilitation registrar. I did my IMT training partially in Cambridge, starting with, and I came to London for medical registrar year, and it was amazing for me. And then it was very confusing whether I should go for rehabilitation medicine or neurology. At the end, I decided to go for rehabilitation medicine. Amin, who is not here today, but he's one of our team members. He created excellent clinical scenarios for us, and he's doing neurology now.
I'm just listening to this webinar.
Oh, I
Mehek,
think someone needs
Interviews,
to
but I
mute
think they're going to
themselves.
record it, so I might log off
oh,
in a sec.
yeah, I can meet them. No worries. And Mehek, you can introduce yourself.
Yeah, great. Hi guys, I'm Mehek. I am a cardiology reg in the Severn region, so that's the Bristol region. And yeah, I did my IMT a few years ago. So Amin and I actually did IMT together down in the southwest. And it was a interesting time because it was during the period of COVID-19. But yeah, we learned a lot from our IMT training. I'm obviously very passionate about medical, training. And we picked up a few skills here and there when we were practicing for our neurology and cardiology interviews, which are both quite competitive specialties. So we thought, why not pass this on? So we've been doing this for a few years now. We hold these webinars and we also offer one-to-one sessions. So yeah, hopefully you guys will take away quite a bit from this session.
Yeah, excellent. So, what is IMT training, first of all? Okay, if you are especially from overseas, there is no such a thing as IMT interview. There is internal medicine specialty training. After 4 years, for example, in Germany, Turkey, US, you finish your internal medicine training and you become a specialist. Whereas in the UK, it's completely different. If you want to do anything in medicine related, you need to do internal medicine training, get your core competencies and some different competencies actually not required overseas. So if you are an IMG, it's going to be very difficult for you to understand, but this is a very essential part of the UK system. It's 2 to 3 years. So there is some group one specialties, we say hardcore medicine stuff, such as cardiology, neurology. They need to do 3 years of IMT training. The last year is medical registrar year as well. And obviously, if you are doing milder medical specialties like dermatology, rehabilitation medicine is one of them, you're going to get away with 2 years. However, please know that a medical registrar year is an essential year, and be familiar as yourself before going into IMT interview. Okay, because you may have questions about what are the essential properties of the medical registrar. you could be asked, because even though you are going to do essentially in your third year, your medical registrar term, you may be holding the bleep in your IMT 2 years, and you may act as a medical registrar. Okay, so you need to be familiar with it. And this is by far is the biggest training programs after GP training. So we have every year almost 2,000 people joining to IMT training. And how many people joined this, applied this year? 9,000 people. 4,000 of you, you are for one of the luckiest one. 4,000 of those people have been invited for an interview, and 1,700 is going to get a post, hopefully. But the thing is, if you are in the first 2,000, you will probably get a training post, okay? Because out of these 1,700, there will be people who applied for 2, 3 things. And even though they got IMT, a higher IMT rank than you, they will opt for something else, like GP. They may have applied for surgery, so they're going to go something else. Okay, aim for the first 2,000. And if you are aiming for more, what do you say? It's like dinneries like London, Cambridge. They are a bit more competitive, so please aim for the first 400, 500. Okay, so the IMT interviews are going to be held in 1 month period between 12th of January and 13th of February. It's a very intense period for us as well. So, and after that, you're going to get your rankings. So when you have your rankings, please don't despair. So if you are in like 2,100, there is still chance that you might actually get a IMT post. Okay, what are the stations? So obviously the first station, and actually which is going to give you the pace when you start it, it's going to be application and suitability for IMT. The important thing that you need to understand, guys, I know that you put everything in your IMT application. So you think that the interview panel actually knows what your achievements are. But in practicality wise, this may not be always the case. Okay? Because imagine that the interview panel will be looking so many different applications. They may not remember what you did. So please mention your biggest achievements in this category. Okay, so if you have like 3 papers, 2 international presentation, these are incredibly important things, and mention those things. And suitability for IMT, we're going to talk more about it later. And then you're going to have first question. It could be ethical questions, professional questions, and it might be some governance question, clinical governance question. I will tell you exactly what kind of question you could be asked and what are the things actually you need to read and you need to familiarize yourself with. Especially if you're an IMG, I'm an IMG, I'm very unfamiliar. When I first came to this country like 7 years ago, I was very unfamiliar with the system. There were a lot of terms basically thrown at me and I couldn't understand what to do. So please don't be in my situation. Please look at the important documents. I will tell you those documents in a minute. And what are the clinical scenario questions? Basically, these are usually for you, especially. You have a good NHS experience. You guys are working in the NHS hospitals. You will have no problem answering those questions, but please answer in a way that you get the full mark, okay? Sometimes mentioning the easiest thing could be the most difficult because you don't even think that it is worth mentioning. You're going to do it, obviously, but please mention that, okay? It could be as simple as hydration, okay? It could be as simple as giving someone glucose because they are hypoglycemic, okay?
Just ahead into the roundabout and take the first exit.
Oh, somebody's driving. Be safe, please. And all of these things also have communication mark, how you relay yourself to the person, how well you are spoken, Do you have any mistakes when you are explaining yourself? Okay. So the station one, obviously your suitability, your application achievements, and communication mark, and station two is going to be uh, everything really, everything clinical wise. So investigation, diagnosis, your differential diagnosis are extremely important, and at the end you are going to do an handover. So these 30 minutes run quite fast, especially from your point of view. From the interview panel point of view, it is a long time, but you're going to be going like this, okay? In between, obviously, there will be technical people who will be checking your ID.
Berkay, sorry,
Going,
someone's just typed that they can't see the, oh, it might just be them. Okay, fine. So someone said they can't see the slides, Hannah Freeman, but I think Hannah is just you. Okay, fine, carry on, sorry.
okay, so these 30 minutes are very important. It's going to go really fast for you. In between, they're going to interrupt you. For example, when the station one is finished, basically they will cut you off. Okay, this is a technical thing. You won't be able to tell anything important after the 11 minutes. So please be careful. Okay, it is not up to the interview panel. This is the technical system that we use, and there is no way around it. All right. So this was the small introduction. Are you guys happy? Do you want me to continue? Am I going too fast? I'm going to continue with my own pace then. Okay, you can interrupt me with your question. So what do we do? Obviously, the first one is your application and suitability for IMT. You're going to present your best bits of your portfolio, and please connect those bits why it is important in the IMT training. Okay, and please be aware, IMT training is a bridge to a specialty training. Okay, as we said, nowhere in the world IMT is a bridge like in the UK. Okay, internal medicine is a specialty in all other countries, but in the UK, it is a bridge to cardiology, to neurology, to rehabilitation. So you should have some sort of idea about what you would like to do in the future as well. Okay, and why you need to do IMT for that. What are the IMT curriculum points actually going to help you to achieve those goals? This is the one of the bits that actually people get confused about. Okay, so especially like for example, last year there were people, there were more overseas actually last year, and they were saying that they would like to be an internal medicine specialist because they like the complex structure. They would like to continue to, etc., etc. But okay, you are not going to be an internal medicine specialist.
Just wanted to add something there, Berkay. So yeah, it's very true that, IMT training in this country is a bridge to other specialties. However, you do need to show enthusiasm towards medicine as a whole, because, you are going to be rotating through medical specialties. So you're not applying for a SD4 or SD3 interview. So when you do mention your projects and stuff, it's good to kind of show a breadth in medical specialties that you may have done, I don't know, a QIP in hepatology and then an audit in acute medicine. So if you have done, obviously, if you've only done something in one rotation, then that's also fair. The most important thing is that you talk about your achievements. But if you've got one QIP in hepatology and then you've done a teaching project in acute medicine, and you've also done an acute teaching project in hepatology, I would encourage using different examples from different specialties, just so it kind of shows that you've engaged in every rotation that you've done so far in your foundation years. So yeah, the interviewers, and I'm one of them. We interview, for IMT as well. People do like to hear that you've taken active kind of role in every rotation that you've been through.
Very true. Yeah. We come to the ethical scenarios now. So ethical professionalism and clinical governance is like a whole. You may encounter any question, but please, before going into interview, obviously on the website we have a lot of explanation about each of these topics. But please read the good clinical practice, principles of ethics. Please know understanding clinical governance. It is not just memorizing 7 pillars. Okay, so how those 7 pillars actually come to an action when you are running a clinic, and familiarity with the good clinical practice. Obviously, we wrote it twice, but we cannot emphasize more. I mean, GMC is the most important organization that we need to abide by, and you need to be very familiar with their Bible. And what do interviewers want to know? Obviously, they would like to know that you are familiar with those things, and actually you can take those principles and put it into an action. Okay, because you're going to encounter scenarios. What those scenarios could be, okay? So, for example, you encounter a problem, okay? This problem could be a medical error. How would you solve this medical error, given the fact that you know all these principles, okay? How you come to the patient and explain the error, how you apologize, how you talk with your colleagues, how you talk with your consultant about this medical error. You yourself, as an internal part of NHS, reflect on these issues, okay? All these things actually will encompass your answer. Again, like another simple scenario, discharge against medical advice. So you can explain discharge against medical advice, okay? You can break the station into 2, 3 parts. You can go and talk with the patient, assess them mental capacity, explain why the patient shouldn't leave or should leave, depending on the situation. You can do benefit and risks assessment, talk with them, try to find the midpoint between you two. You can do a safety net, but please bring some of the principles of good clinical practice, good medical practice into the discussion while you are explaining the scenario. Whistleblowing, it's another important thing. You need to familiarize yourself. You are not, guys, I mean, we deleted the junior doctor term, isn't it? You are a resident doctor, and whistleblowing is some of the things that actually not only the seniors do, you may need to do as well. If you are encountering something is not right, and how you do the whistleblowing. For example, when you have a colleague who is struggling, how are you going to go about by them? Okay, how are you going to help them? Or you have a consultant who is not really go by book. Okay, this might be why this your consultant not applying to the guidelines. Maybe he has his own treatment regime, which seems to be a bit harming the patient. How would you go about it? Okay, that can give you a lot of different scenarios, but when it comes to your answer is going to be about the good clinical practice, NHS structure, and obviously principles of ethics.
Yeah, I think I'll just add on one thing. The key here is to identify what the ethical dilemma is. So, in an ethical station, there will definitely be an ethical dilemma, or there'll be a clinical governance issue. And the quicker you identify that and communicate it to the interviewer, the easier it is for them to kind of tick it off in their, scoring sheet and say that the candidate was able to correctly identify the dilemma or the ethical situation. So that's what you need to get yourself in the practice of doing when you kind of, practice these ethical questions. There will definitely be an ethical dilemma. It'll be a clinical governance issue, whatever it is. The quicker you get at identifying it and communicating it very clearly to the interviewer, the easier it makes it for them to give you the higher points.
Very true, Mehak. Yeah. And we come to the clinical station. Okay, so they will stop, and another interview panel is going to come. Obviously, 2 consultants are going to be there, or one of the senior registrars will be scoring you. And usually, the clinical scenarios are the easiest one. Okay, so please try to get the full mark. Okay, because these are the questions you will be doing all the time. So what are the important things you need to do? So you need to assess the patient, okay? You need to have a diagnosis, differential diagnosis, more than 3, 4 at least, and it needs to have a logical order. How you are going to manage them, how you're going to communicate this issue, and how you're going to escalate. Escalation doesn't only mean that I'm going to call my senior registrar. Escalation to which department, how, where this patient is going to stay actually. Are they in the A&E, for example? Are you going to let this patient sit in the A&E, or are you going to arrange somewhere suitable for his or her needs? And then they will ask you to, Dr. Berkay, could you please hand over this patient to a stroke consultant? Okay, and you will have 1 minute to do that. Okay, so over the years, there are some pitfalls, common mistakes that people seem to do over and over again. Okay, sometimes their answer is not well organized. Okay, they mention everything they need to mention, but when it comes to organization, there is no organization. So they throw in a few differential diagnoses and they give the management, and then they go back and try to look what are the important things in the scenario and history, and they throw in a few physical examination, possible findings, and they change their differential diagnosis again. I have no doubt they know what they're talking about, but when you listen to it, it is just so difficult to follow. Okay, so you need to have a logical or well-organized response. And remember, the clinical question is going to be divided into 2 or 3. So you're going to get more and more questions as you go along. Okay. And also, there is not one established clinical scenario. Okay. Sometimes they feel like there is a clinical question and they need to, let's say this is a rabbit, and they try to catch a rabbit. They ask like, oh, does this patient have a diabetes? If they have diabetes, they would do that, and they wait for an answer. Okay. So please don't do that. If the patient had a diabetes, they would have given you, okay. If they didn't give you, but you think that it is relevant, please create a differential diagnosis tree. If this patient have diabetes, that might be the cause of dizziness. They may be hyperglycemic or severely hypoglycemic. So I would do this and that. Okay. Or they ask a question, could you please tell me what the ECG shows? Okay. So if it hasn't been given to you, either they will give you later in the scenario, or imagine that they didn't give you. So just tell yourself, okay, the ECG, if the ECG shows ST elevated MI, I would do this and that. If ECG shows this, I would do that. Okay, so you need to create a differential diagnosis when you are okay, are you familiar with differential diagnosis tree? Like when the symptoms comes, this might be possible differential diagnosis, and you say you would do this and that. Okay. And the panel will understand actually how you think. And another important thing is, especially when you are a bit senior, you sometimes think very complex. Okay. Some of the most important things are very obvious things. Okay. For example, the patient has dehydration. Okay. They give you the dehydration symptoms, they give you the dehydration vitals. The patient has a severely low blood pressure. Okay. Just hydrate, isn't it? If you don't say hydration, if you don't say that I'm going to give IV fluids, this is probably one of the most important bits in the management, and you're just going to miss a point. But you will be giving a lot of complex differential diagnosis, but still one of the important bits, they're not going to be able to score you, even though they like to. Okay. And for example, the patient is hypoglycemic. It's obviously in the question, but you don't mention that you need to give glucose. Okay. These are very simple, but people usually, not usually, but they can lose marks. And appropriate escalation is very important. Not informing the family or patient, it's another thing that people miss. informing family is one of the things that you need to do in the management, isn't it? For example, you have a very sickly patient, okay? You basically treat them well, you manage them, you create the investigation plan very well, you discuss with the appropriate specialist, and the patient is going to stay in HTU, for example. But come on, if the patient is going to stay in HTU, you need to obviously talk with the patient and also the family when appropriate. Does this make sense? I'm sorry, I can't follow the chat. Mehek,
Yeah,
is there?
there are a few questions, Berke, and I've just said I'll let you finish and then we'll address them.
Brilliant.
So one of the questions was how do we decide about our approach? So A to E or history taking, especially if the patient is in clinic. So I can answer that. I would advocate for it depend actually it really depends on what you're comfortable with. So when you're practicing scenarios, if you have a certain way where the key is to cover everything. So if you have a certain way, like for example taking history from the patient, that helps you cover everything in a systematic way. So like you like to interrogate about patients, I don't know, cardiovascular system, then respiratory, then GI, and then moving on to the kind of their skin, then that's fine as long as you cover everything. If you're, and I've had candidates do both and do it well. But if you're the kind of person who prefers doing A to E and you think that way you're not going to miss anything, then you employ that approach. The only caveat is that if you've got a sick patient, they've already told you in their little spiel that the patient is tachycardic, they're borderline hypertensive, or they're hypoxic, then your main priority is to make the patient safe and make sure you address those bits first. So you'd probably start off by saying, well, this patient seems like they need a higher level of care, so I'd make sure that they're in a place of in an appropriate place for the level of care they require, and I'd like to start off with an A to E approach in seeing this patient. So it just depends. If they've given you an outpatient, and I remember having an outpatient scenario actually myself, and patient can clearly talk, then I'd probably just start off by saying, and especially if they haven't given you obs, I'd probably just start off by saying, I'd like to get a set of obs for this patient. And if everything is stable, then I'd move on to taking a full history. And then you could do a more system-based approach. So I hope that makes sense. Like you do have to judge the scenario at the time, and think about what is appropriate for this patient. If they're clearly sick or they're borderline, like hypertensive or whatever, then you want to kind of address that as soon as possible. With every station, actually, you want to address the main problem as soon as possible and show them that you're not an unsafe doctor. But equally, if they've told you someone has just come in with a bit of tiredness and they're sitting in the outpatient clinic, it could be anything, couldn't it? The differentials for tiredness is huge. So you could go ahead and do a full history taking. And then we have got somebody else saying, if comorbidities are already given in the scenario, are we still supposed to ask these while asking history? Again, it just depends. You could say that I can see the patient has a background of type 2 diabetes, hypertension. I'd ask them again to make sure there isn't anything else that they haven't disclosed. But you can move on and address those comorbidities and say, I'd like to get a blood glucose level to make sure they're not hyper or hypoglycemic. I'd like to do a blood pressure check. So you just have to, judge it at the time, but also you don't want to take too long if they've already given you some information there.
Yeah, very good. Yeah, exactly. And also, another thing is, I mean, this is a very human interview, isn't it? So
Yeah.
you are talking, you're a registrar, you are talking with two consultants. You can paraphrase the things, okay? For example, there are a few important things in the vignette, like for example, the patient is hypertensive, they have rheumatoid arthritis, but they have a headache as well. So you can also always say, okay, there are a few things concerning me at the first glance as soon as you start, and you can paraphrase, like for example, this patient has severely hypertensive. I can see that blood pressure is 170 over 80. One of the things that comes to my mind, obviously, could it be a bleeding, but also there is rheumatoid arthritis. Could there be other rheumatological conditions? So what I would do and then continue. Okay, this is, for example, a very nice start. So you show understanding as a whole, you paraphrase this station, and basically you drove the interview panel into your scenario while you are answering. I believe this is a nice start. You don't necessarily need to
Yeah.
start like this, but
Yeah.
I
This
love
is
it.
yeah, and Berke, absolutely right. Actually, you have to develop your own style. But whatever style you develop, like, Burke has obviously shared his, and I've shared mine, but you just have to make sure you cover everything and you don't like, fumble too much on the day. So practice is key with all of these stations, but you sort of have to develop your own style and just, judge the scenario on the day and take it into take the patient's kind of, presenting complaint into account in how you're going to take the scenario on further. Okay, so someone has asked, is the clinical station split into sections? For example, history taking, then answering clinical questions, and then handover. So it just again, it really depends. Like Burke said, you're gonna get a vignette. And back in the days, actually until last year, they used to give you a minute to prepare, and you could have a piece of paper and you could write down keywords. This year, I don't think they're doing that. I think you go straight into the scenario. So they might give you information as you go on, like if you've got quite far within the first couple of minutes, and obviously the station is much longer than that, then they might tell you, oh, well, now the patient's dropped their blood pressure. But maybe if you haven't got that far and they just kind of want to, ask questions about your knowledge, if you haven't mentioned differentials, for example, if you're taking too long and going through history, the interviewers have quite a free hand, essentially, in all of this. So they just have to judge the candidate and try and help them score as high mark as possible. But if a candidate hasn't, yet mentioned any differentials, then they have to ask, what differentials are you thinking about? What investigations would you like to request? But on the other hand, if a candidate has already given them all of that, then they might make the patient a bit more sick. They might say, well, another specialty has got involved and they've said this. So it just depends. I mean, um, vignette that the interviewers get on their piece of paper is quite long. It just depends. Not every candidate will get through it all, and not every candidate needs to get through it all to get full points. You can still get full points as long as you've covered the main bits. So it depends. Um, then we've got most of the time A to E approach is more or less same for every presentation. How can we make it scenario specific? You absolutely can. Because if your patient is complaining of shortness of breath, when you come to examining the respiratory system, obviously you're going to be more interested in that. So when you say, oh well, moving on to B, the breathing, I'd like to know what patient SATs are, respiratory rate is. I'd listen to the chest and auscultate for crackles, crepitations, and literally express what it is that you're trying to rule out. So, is there dullness to percussion? Could it indicate an effusion because they're presenting with shortness of breath? Is it a unilateral effusion? Can I hear it on both sides? So you absolutely can. And then we have got, when taking history, how much time should you take with asking questions? Example, asking each question is like, have you lost weight? How much weight have you lost? Over how long? I mean, again, I think it just depends on how quick you talk, or, again, you have to think about where the money is at. So if your patient is presenting with any red flags like, loss of appetite, they have lost weight, whatever, then obviously when you ask questions, you base your history taking on that. And then in the end, you can say, I'd also just like to make sure that the patient's breathing is okay. I'd ask them questions about their bladder, their bowels, whatever. But you might want to, ask more about, okay, so how long has it been since you've been losing weight? How much weight have you lost? Is it intentional? Is it unintentional? It's just like what you do when patients come through the take. If someone's complaining of chest pain, your whole history taking then is really about chest pain. And you go on to ask about their bladder and bowels quickly and say, well, is everything else okay? Your bladder, bowel, are you eating and drinking okay? And, it's a real like interview. People are clinicians, they're not actors, so they expect you to do exactly that, exactly what you do on acute take. When asked this question, how will you approach to this scenario? After doing A to E, we have to do entire history taking as well.
Mehak, shall we continue and maybe we can
Yeah, I think
answer
so. I
more?
think I'll try and answer some of these questions on the chat. A lot of them are about the clinical station, but maybe Burke will answer some of these as he's
Yeah.
going through.
So, guys,
Yeah.
what do you need to know? Especially if you haven't worked in take or acute medicine, it is going to be a bit daunting for you, okay? If you have done take, you will know that how we explain the scenario to the consultant when we are giving a handover to a registrar at the end of the shift. It is going to be very familiar with you, but if you haven't, it's going to be a bit daunting. Please go and do a few shifts in the take. What are the things that you need to know in neurology? Please know all the medical emergencies. Okay, in neurology, obviously, you need to know the stroke, headache, confusion, unconscious patient. In cardiology, there are so many scenarios it can come to you, but obviously, chest pain, dissection, breathlessness, because they will give you some vague symptoms. They're not going to give you exactly what's going on. Okay, so you need to do a broad, you need to start with the broad differentials and then narrow it down. Because GI, again, they can ask you, they can easily give you an upper GI bleed, okay, and you need to take it from there. Geriatrics is very common. They may give you a simple fall, and you need to basically do a lot of differentials. What may have caused the fall? Endocrinology, again, probably diabetic ketoacidosis is the most common, but please know other things as well. So if you go to our website, there is almost 80 scenarios that you can go through, and we cover almost every one of them. And in rheumatology, it is less common, but still, please know joint pain, isn't it? The common joint pain, septic arthritis, rheumatoid arthritis, reactive arthritis. These are very important. And please ask yourself what could cause significant harm to this patient when you are doing your differential diagnosis. And please tell those differential diagnoses first. Okay. Okay, let's do an example scenario. Okay, that is something similar that you may encounter in your own interview. This is a screenshot from our website. One of the question, again, we give you the answer as well. This is a temporal arthritis question, but you won't know, obviously. Let's imagine 70-year-old gentleman with a background of osteoarthritis, hypertension, previous ischemic heart disease, and comes in with complaints of a unilateral headache since 2 days. He has never known to have headaches in the past. How would you assess this patient? So how would you start? So basically, you're going to have 1 minute to think, to make a note. You can start by writing down the important points, and you can start writing down your A2 assessment. And sometimes it's important your differential diagnosis on your paper as well, and why it could be, why it cannot be. Okay, for example, unilateral headache. If you have a headache due to hypertension, it's usually bilateral, but migraine could be unilateral. Giant cell arthritis obviously could be unilateral. Sometimes, obviously, if you have a problem with your eye, it could be a unilateral headache. So all these things could be written down. Okay, how are you going to start the station? Okay, so it's a very easy entrance. You can say that you're going to take a history of the headache, and you're going to you can ask about Socrates question, like site, onset, character, radiation of the headache, aggravating factor, relieving factor, severity, and then what was the other things associating with the headache, okay? Such as visual symptoms, nausea, vomiting. Obviously, have you ever lost consciousness due to this headache? Do you have any jaw claudication? After finishing your Socrates, this patient seems to be not overtly sick, but just to cover everything, you can do A2A assessment. Okay. After you finishing this, they will tell you a bit more information. Okay. They will come to the second part, and they will tell you, okay, this patient's headache are associated with jaw claudication and is exquisitely tender. When you palpate his left superior temporal artery, you're unable to feel appreciation at the left STA either, and his bloods are still awaited. What would you do next? Okay, so first of all, we haven't mentioned bloods, so we need to probably tell which blood test we are awaiting. We may get score, we may get additional mark from that. And also, this is a giant cell arthritis, right? So what do we need to do? It's hopefully one of our differential diagnoses was giant temporal arthritis. So these two things, jaw claudication and not having the pulse, is supportive of that diagnosis. But we need to do more. We need to ask about obviously, how is the visual disturbance? We need to do additional question about oh, thank you very much for meeting. We need to do additional visual tests. We may need to look at the back of the eye as well with ophthalmoscope. And now, who are the things that we need to escalate to? Whoever is going to start the steroid, if we can start in outpatient clinic, that's brilliant. If the hospital doesn't allow us, we need to create a bed for her, for him immediately, and start the steroid treatment. This patient needs to be seen by a rheumatologist. It may differ from hospital to hospital, but hopefully in the first 24 hours, even less so. This patient needs a biopsy to get the accurate diagnosis. And obviously, we need to inform what we did to the patient, and the patient, if there is a family and the patient may want us to discuss with the family, we need to do that as well. And this would basically wrap up our station. You can do some additional things as well, depending on different answers, but this is a good scenario, what you're going to encounter. Sometimes there is a third question, okay? But rarely. Anything you would like to add, Mehak?
Yeah, no, not really. I mean, that was a great example. Yeah, and that's literally how it, goes through. And what I said earlier about the brief on their piece of paper might be quite long, because some candidates might be quite fast in getting through all the main bits, and they might need a little bit more stimulating. But some candidates will take a bit longer. So it just depends. As long as you've covered the full kind of, diagnoses, differential diagnoses, investigations, treatment, if you've got that far, and you've done physical examination, history taking at the start, and most of all, you've made sure that you've been a safe doctor all along, then you'd be able to score kind of the top, points. So yeah.
Yeah. And we put this slide because, I mean, unfortunately, in each day, there's usually one person who have really bad internet or really not high quality camera, or basically the background is really noisy. So please, guys, be careful about these things. This is very easy, and even though we don't score you on the environment technical issues sound, if your sound quality is good, this is a huge gain for you. If your camera quality is good, again, it's very impressive as well, because we all will be using our normal webcam that the NHS provides. But if you have a nice cam with high quality, that's very important. Make sure that your internet is functioning. This is probably the most important thing in the whole day. If your internet cuts off in the middle of the interview, unfortunately, there is not much thing to do. Okay, so there is a possibility that you may get another date, but it is totally depending on the interview committee. Okay, they don't need to repeat it just because you lost your internet, because you are saying that you have a stable internet connection to come to the interview. And having a class is important. You will be speaking almost 30 minutes nonstop. Be ready 15 minutes before. And this interview day is quite a nice day, actually. Okay, so you will be. It's a very professional day as well. Everyone that you're going to encounter are trying to be as nice to you as possible. From like technical stuff to consultants are trying their best to mark you higher. Okay, they don't try to mark you down, and they don't even know what's your rank going to be. Okay, on the day, obviously, they see some of the candidates are better than the others, but they have no idea which candidates are going to have an IMT seat at the end of the day. Okay, and smiling, having proper social expression is very important. Okay, so how do they score you? Basically, your scoring is going to be done by two people, okay? The two consultants or registrar, whoever it is. And you need to basically aim for excellence, okay? So excellent is the 5 points, and please try to get excellent from both sides. And basically that means that you are at the IMT level anyway, and maybe higher. So your answer covers everything. You can think collaterally. You know how to NHS structure works, so you are perfect IMT candidate.
Yeah, and I'd just like to add there that, it really is doable. I know when you look at these like scoring sheets and you come to webinars like this, you feel a bit overwhelmed. But actually, the only difference between people who score the higher, marks versus the ones who don't quite make it is the fact that the ones, who score higher are just well prepared. They've got a structure, whatever the scenario is that they're given, they've got a structure that they've well practiced, and you can tell that on the day because any situation doesn't overwhelm them. They've got a structure, they can follow it, and eventually they can hit those higher scoring points. So you just need to have a structure, and practice is really the key here.
Yes. I mean, obviously, weighting of the questions are different. For example, the patient handover has a lesser weight than, let's say, IMT suitability. But at the end of the day, you are trying your best. So I don't think the weightings are that important. Obviously, they are trying to be as fair as possible. But for us, I believe it's not important thing. And after the interview, obviously, you're going to receive emails, you're going to get oral updates. And when you accept an offer, by the way, if you are waiting interview results from your other interviews for other specialty trainings, as soon as you accept one, the others are going to be basically withdrawn. So you need to be aware of that. And you can obviously hold an upgrade. So for example, you have received a deanery that it is not first choice. You can hold it and you can wait for an upgrade, and maybe in a few weeks' time, you may receive an upgrade. Okay, so lastly, guys, if you have received an IMT interview, you have a chance to get into IMT training. Why I'm saying this? Okay, the other day I was talking one of the international medical graduate. She has been here for 1.5 years. She did a lot of things, but still she has this imposter syndrome. Okay, so she doesn't think that she has enough knowledge, enough experience to get into IMT training, but she is going to get the interview just for experience. This is total ridiculousity. Okay, guys, if you get an IMT interview, you have a chance to get an IMT seat. Okay, you may not have a PhD, you may not have a multiple publication, maybe you haven't had an international presentation. Okay, but still, if you study well, if you answer your clinical question well, if you answer your ethical question well, you're going to get an IMT seat for sure. So please don't get disheartened by your lack of things. Okay, focus on the things that you are strong, and you have at least 2 weeks. Okay, these 2 weeks could be a game changing for you. So what we will be doing another whole day webinar course next week on Sunday. You can come to that one. We will be also having one-to-one interviews, so you can check the website. You can book me or Mahak or Amin, whichever is like suitable for you. We will try to accommodate your needs and try to practice as much as possible. I shared our WhatsApp group. Please come to that WhatsApp group and practice with each other as well. That's another important thing.
Yeah.
Volume is very important. The more that you practice, the more you're going to get better. And you are not zero either. You can give each other constructive feedback. If you book with us, we're going to obviously give you a 90-minute session. So we will do a mock interview with you. But after that, close to an hour, we will try to tailor your answer. What are the things that you say it was good and could be improved? And what are the things that actually you couldn't say, but you should have said? Okay. And hopefully you got this.
Great, thanks, Berkay. We've got about 6 minutes left, so I'll just quickly try and get through some of these questions that have popped up on the chat. So someone has said, what common ECG and chest X-ray findings should we know? So anything that you're likely to encounter, when you're doing your foundation training, or if you're a fellow or whatever. So chest X-ray, consolidations, diffusions, a mass, if it looks abnormal. If you really get stuck, and this is what I tell everybody, try and find the abnormality. And if you can't find the abnormality and point that out, that's when you're slightly in trouble. So if you can even just say, well, I can see that isn't normal and I'd like to investigate it further, either by getting a second opinion. If you really get stuck, you could say stuff like that, because remember, you're applying for an IMT training post. You're not applying for a registrar. You're not the most senior person in the hospital, and there's always someone to ask. So you could say, I'd be worried about this finding in the right middle zone. I would get a second opinion either by ringing the radiology on call, or I'd like to ask a senior colleague, a senior SHO, or, the kind of things I'd be worried about. Is this a cancer? Is this, a consolidation? Is this an atypical, consolidation? So you could ask those, you could say those things. And then ECG, again, bradyarrhythmias, life-threatening bradyarrhythmias, tachyarrhythmias, um, heart blocks, stuff like that. I mean, again, things that you would hopefully be able to identify. And again, you could keep it broad if you're really not sure, is this, an SVT, AVNRT, whatever, which, I wouldn't expect somebody at your stage to really know in within a couple of minutes. You could just say this is a narrow complex tachycardia, or this is a broad complex tachycardia. So just think about it like that. How much prep is needed? Some people are saying more than 4 weeks, but I didn't get the interview date I wanted, so I only have 10 days. I mean, obviously, the more the better. So you're saying that you've, only got your interview recently. It's fine. You just have to make the next 10 days count. And you can, practice every day, have access to a question bank, have a study partner, if you can find one. That's why we have this like group chat, which I think now has over 200 candidates, doesn't it, Berkeley? So it's a great platform to meet other people like you, ask them if they're free on an evening after work to have a little practice session. We obviously run other courses and one-to-one services, which you can sign up to if you wish. But you can really make the next 10 days work for you. And
Yeah.
you'll definitely come out, or show up to be more prepared than what you are now if you put in even like an hour a day. Uh,
Mehmet, there is one thing that I would like to mention actually. So please, guys, before coming to the interview course or booking a one-to-one, please look at the scenarios in the website. Okay, we have compiled like most common scenarios that you may encounter. We created like very concise answers. So it is not like we don't write huge amount of things. Okay, it is not like copy paste from like some chat GBT. So we are trying to give you the most concise answer that you need to know, and it is very easy to follow. And also for ethical scenarios, there are some videos as well, like mock interviews. So you can watch those things, and basically you can steal the phrases that we have used on the website and use it on your own interview.
Great, thank you. So ethical scenarios, for scenarios like difficult colleague, if they agree to what we say, do we still need to escalate? Again, it really depends on the situation. If they've been an unsafe doctor, so for example, they've turned up, intoxicated, then yes, it then becomes a property issue and you do need to escalate. And again, remember, you're a foundation doctor, you might need to get advice, and it's all about reflection for yourself as well. So you can say, having been through in this difficult scenario with my colleague, I'd like to seek further advice from my clinical supervisor. It might be, if it's more kind of a legal issue, let's say, you might go to your defense union, so MDU. There's always BMA, on offer. So yeah, as a F2 applying for an IMT, and even like at my stage, if you've been through in a difficult kind of ethical dilemma, it's always good to run your ideas, through somebody more senior to you, or even just for a second opinion. And always say that you'd reflect on this, either in your portfolio, or have a reflective session booked with your supervisor. I have previous clinical experience in medicine as well as in surgery. How will I justify my surgical experience as commitment to specialty? it really depends what you did, and you don't have to mention that, I did HPB or vascular or whatever. It's what you did in those rotations. The skills you would have picked up would be interchangeable. Any audits you did, any teaching projects you led, any cases you wrote up and they were published. It's not, nobody is really wanting to know how you manage a patient who presents with, I don't know, kidney stones. That's not what they're going to be asking, and that's not what you need to talk about. But what you need to talk about is any projects you took on, and the skills you learned from it. So, what are the skills? Did you become more organized? Have you got better, communication skills? Did you go and present this regionally? So these are the kind of things you need to think about in your 2 minute spiel at the start when you get to give your presentation. I'd encourage everyone that whenever you mention a project you've taken, on, or an achievement that you've mentioned in your self-scoring, and you want to elaborate more on that, always think, what is it that you took away from it, which will help you to be a better doctor overall, but specifically a better IMT. And these are all like, communication skills, team working skills. The list is, endless. So just think about stuff like that. What is the website? We'll post that soon. How much weight would interviewers put on getting MRCP Part 1 in FY2? It's commitment to specialty, isn't it? So they might like that. Again, different interviewers may give you points for different things. You might just come across as a very well dedicated, IMT, future IMT doctor. So yeah, it just depends on them. I think, if you haven't got MRCP Part 1, I wouldn't worry too much about it. But at the same time, if you've got one, if you've done Part 1, then you should definitely mention it, because that shows your commitment to the specialty or to IMT training, but also how organized you've been. And you can really flaunt that, whilst being a full F2 trainee and, doing your full-time job, you managed to organize your time to study for Part 1, in the evenings or whatever, and then successfully did the exam. So I think, it's definitely commendable. So definitely mention it. But if you haven't done it, then that's also okay. There's other things that you can, bring up, and inevitably there'd be things that you would have done, other people would have done, that are definite, that would also show their commitment to IMT training. Where's the link info for the whole day course on 11th? Is it free? I'm afraid it's not free, because, all of us give a lot of time to this. So there is a fee to this. But it's all on our website, and you can have a look at that. And I believe Berke will be posting this on the chat as well. So have a look at it. Contact us if you have any questions, and we'd be more than happy to answer. When asked the question, how will you approach this scenario after doing ET? You have to do I've done these, haven't I? If I just want to
Yes.
sign up for a one-to-one session, is this available?
I answered
Yeah.
those. They can email us.
Yeah, so
Um,
email Berkey, and then we'd be happy to kind of organize one. And you can state your preference if, I mean, this is obviously not a higher specialty interview. We have different specialties, but we've all been through IMT training, so I don't think it matters too much. How to join the next weekend session? I think I've answered that one. Please send link to website. Yes, I think Berkey's done that. Um, Berkey's answered. And how much is it for a one-to-one? Email Berkey and he will, reply back, if that's okay. Great. Any other questions? F1 query. How have you found success with approaching people for publications? Do you research them before? Do you plan your own project, then pick a supervisor? There'll be projects going on in every department. So if you're a full-time doctor in any trust, to be honest, there are projects going on everywhere, isn't there? And there's always one consultant in every department who takes on more of a kind of research role. And it's easy to find that out, or you could just ask, your clinical supervisor at the time, whatever job you're doing, and just approach them. And, no one's really going to turn you away. Just approach them and say, I'm really interested. I'd love to get involved in a project. What people like, especially as the more senior you get, is, somebody who appears, passionate, and somebody who will deliver. So if you've asked, it already means that you want to do this. And as long as you kind of like show them that you will deliver things on time. So if they've asked you to do a bit of literature review, within a week you've got back to them and said, well, I've read up these articles, whatever, they're more likely to get you on. So yeah, just ask. And if there's not much going on within your own department, it's also okay to walk on another ward where there's a lot of research going on. There's a particular consultant who does a lot of like publishing. It's also okay to walk there and just say, or email them if they're not on site, and just say, can I make an appointment? I'm really interested in doing some projects, doing some academic work. I'd love for you to get me involved in this, and I'd really like to take part and learn from you. And people love that. Okay. Can I just clarify whether we get prep time after the clinical scenario? I think you literally have to, you can make your notes whilst they're reading out the scenario. Sometimes the scenario comes up on your screen. Sometimes they read it out to you. I'm not sure. I've been told different things, but
Heck, they will be able to get 1 or 2 minutes, like 90 seconds or something,
yeah,
to write it down. And obviously, they will be reading you as well, but they will
yeah,
show you the question. And if
yeah,
there's any images, they need to show you, like
yeah,
chest X-ray,
yeah.
basically the things that you need to be aware of: chest X-ray, ECG, and obviously you need to know ABG. Okay. And when it comes to ABG, guys, please be aware they may not need to put the normal intervals to you. Okay, so know the normal intervals. And very, very rarely they may put a CT scan, obvious CT scan. Okay. Like
Yeah, but it'll be really obvious. And like I said, keep it simple for yourself. If you're really not sure, you could just say, well, there's clearly an abnormality there and I am worried about it. I'd like to bring the radiologist to get further advice on what this could be, or ask my senior. Um, Someone has said, any advice on common clinical governance topics to revise? I think we covered all of that in our webinar on Sunday, but off the top of my head, clinical governance is usually, what do you think, Berke? I think we
so
have, we have a
obviously,
whole slide on this.
when it comes to easy is the clinical governance. Okay, what do you understand from clinical governance?
Oh
Obviously,
yeah, they ask
seven pillar,
definitions.
they may ask this, or they may
Yeah.
give you a scenario. Okay, those scenarios might be something went wrong in the clinic, kind of type of questions, and you need to solve this problem in the short term and in the long term. In the short term, it could be making sure that the patient is safe, and in the long term, you need to make sure that this problem is not going to be encountered again. Okay, so, and obviously you're going to answer those questions along with the clinical governance principles. Does this make sense?
Okay, and then someone said, in the 2 minutes presentation, should you say about your portfolio and motivation and why you're suited to IMT? Yeah, so everything you talk about in your portfolio, you should probably back it up with a line to say, this has taught me this skill, which I think would be valuable in my future career as an IMT. And that just kind of links it all together nicely. And it makes the examiner understand that you're not just saying things for the sake of saying it. You know exactly what skills you've learnt from doing this project and how it make you a better doctor, if that kind of makes sense. And in the end, most people just have like a sentence or a phrase to kind of round up their portfolio and say, as well as this, I'd just like to say that I'm very passionate and motivated towards internal medicine as a whole, and I look forward to starting my career in internal medicine and eventually rheumatology or dermatology or whatever, and that just kind of rounds it up nicely, something along those lines. But yeah, everything you say in your 2 minute spiel before that, especially any projects or any achievements you're mentioning, I would definitely back it up with what skill you've learned, and then I'd probably just drop it in here and there that this will make you understand that this will make you a better IMT doctor. Um, yeah. Any other question, guys?
Thank you very much, then. Thank you, guys.
Great. Yeah, have a good evening and good luck if we don't hear from you again. Um, and thank you for joining.
Yeah, and please do let us know after your interview if you get a seat. Please do let us know. We will be in the WhatsApp group anyway.